We're gonna roll straight on into Jace Provo. Jace, if you want to just take over, and then I think you wanted to introduce yourself, so we can have you.
Uh,
Yeah,
can you hear me?
I can hear you.
Excellent. Okay, so I actually don't like writing down my intro for other people to read, so I'm just going to do it myself. I'm talking about private practice. And when I was talking to Dr. Hudson about this topic, I have a strong background in business, and I'll give it to you in a little bit. It's like, how do you do all this in 20 minutes when you could spend 4 months on this? By the way, I'd like to say the last lecture was superb. And as a guy who's been doing this for a long time, you hit it on the nail. It was perfect. You said it better than I could have. So, congratulations. So my background, I did my ER residency at the University of Chicago. I actually started doing consulting work with the NBA in 1992. So I am an OG in sports medicine, although it doesn't feel like it. And time seems to go by rather quickly, but that's the way it goes. I was medical director of my own ER at 31, pretty decent sized ER. And as a regional director, I worked for Team Health. It wasn't Team Health. I was a regional director over 10 ERs at 34. I was regional VP at 35, which means I had direct profit and loss responsibilities for the facilities. And then I was a senior vice president of operations for Team Health at 38. And at that time, I had about $80 million in budget and about 150 employees in 17 facilities. And somewhere along the line, I went back and I got a business degree or the equivalent. I got a master's in healthcare management from Harvard, and I was doing consulting work with the NBA. These careers were striking into each other, so I told the NBA I had to leave. And Adam Silver, who's now the commissioner, but he wasn't the commissioner then, said, "We don't want you to leave, so we'll hire you full time and you can come work for us." And I became the first VP of medical affairs for the NBA. And I progressed through that for many, many, many years, became chief medical officer. The job didn't really change that much, but the titles got better, and I guess so did the pay. When I decided it was time to retire, I actually left the league and I opened a private practice in sports medicine. Now, when I was doing all this stuff, I always practiced, right? So no matter how good the job was, you don't want to lose your clinical skills. I had it in every contract that I get to practice on the side because medicine is a perishable skill and business jobs are temp jobs. And it may be a long temp job like me because I was with the NBA for 25 years, but eventually it's going to go away. And if you forget how to practice medicine, you've lost a valuable skill. And one of the main complaints that a lot of people have when they're dealing with a quote unquote suit is that they're not us. They don't live our life. They don't know what we do. And so I always took that very seriously and made sure that my clinical skills were as strong as anybody that I was dealing with, and I could intubate and I could do the whole 9 yards. Now, Anna talked a little while ago about, and someone asked, how do you go back to do a fellowship? Well, I did it actually. I did my fellowship when I was in my early 40s, and it's very difficult to do. Some of my program people, I trained at Northwell, by the way, are on this call. So, because I wanted to get better, I wasn't really that interested in sports orthopedics per se, but I was interested. I needed to do my job well with the NBA, and what I figured out is that I really, really liked it, right, and I enjoyed doing it. And so when I was getting towards the end of my time with the NBA, because listen, I mean, I've done 5 Olympics, I've been to 30 All-Star games, I've been lots of finals. It wasn't really that much fun anymore. And, it's supposed to be fun, right? So I actually left and I opened a private practice. And I opened it by myself with no help. And so I put up a shingle and good luck. So the meat of this talk is going to be about what is private practice in sports medicine. And I want to say, first of all, that emergency medicine, sports medicine, we're a small, malignant, happy group of people. We all know each other. It's a small specialty compared to the size of ACEP. And I sit there and think about this. You go think of all the fellowships you have in emergency medicine. The vast majority leave you in the pit, right? You end up staying in the ER, or maybe you can go to the ICU, right? Sports, you can leave. Sports, you can actually go out and practice out in the universe, right? So I think sports medicine is great. I'm a huge advocate. I talk on this all the time. Try to build our numbers, try to get the numbers up. Every faculty member in here is doing the same thing because we love what we do and we love getting other people to love what we do too. Now, for those of you who are in training, a lot of times this all seems daunting, like it's all been done and there's no opportunities. So, not true. And I felt the same way. There's so many areas to go into, there's so many places to go with this. The world's your oyster and it's all wide open. So, it makes it kind of interesting. So, why EM sports? Because we're good at stuff. A large portion, you can make sports medicine into anything. You can do concussion, you can do cardiac screening. I'm an ER doc. I like to stick needles in things and do ultrasounds. So you can do clinical orthopedics. We do procedures. I mean, some of the sports medicine people are not really procedure adroit or procedure friendly, but we are. And as a guy who did a ton of sideline and did a ton of clinical care with professional athletes for a long time, not much scares us. And that's actually a real plus, right? So if somebody faints or passes out, it's easy. If somebody had a cardiac arrest, God forbid, I mean, heck, we do that every day, right? So this is right up our alley. So to talk more about what the options are for private practice or for practicing sports medicine, because say, okay, I did a fellowship now. So one of the big things that I've heard for years and years is that ER pays so well, how can I possibly take the pay cut and go do sports? I can tell you that I make more money doing sports than I ever did doing ER. And that includes if I were working full time, because you can set this up to where you make a really nice living. Yeah, I mean, I work Monday through Friday, 9 to 5, no nights, no weekends, no call except my own people, no holidays. And I make more than the average ER doc. And you can too. I'm not the only one who does it. So the next question is, what kind of job do you look for? Or what do you do with it? Most of the people that are on the faculty here are academic EM sports people. Noble career and well worth it. You can go do that. You can teach. You can be a faculty member at a fellowship. You can be a clinical faculty member. You can stay in the ER and be the ortho expert. I'll tell you a couple of things I learned along the way. Grandma who's intubated isn't filling out a patient satisfaction survey. But the person who comes in with shoulder pain in the middle of the night and we say, go home, there's nothing wrong with you, why are you bothering me? They are, right? So simple stuff like how do you treat a shoulder? How do you treat a knee? How do you drain a knee? How do you give a shot in an ankle? How do you pull the blood out of an ACL tear? These are great patient satisfiers, and you can do a ton of that in ER. I mean, it's all over the place. I saw much more and variety of fractures when I was an ER doc than I do as a sports guy, right? So there's a wealth of opportunity there to practice and to improve clinical patient satisfaction, right? Because it's the disgruntled patient that you say, go away, you're bothering me. They're the ones that are going to call the CEO of your hospital. A lot of people, what they'll do is they'll try to split their time between ER and sports clinic. It's kind of hard to juggle because the ER director wants to fill the schedule, and it's kind of hard to fit that in. But those are very reasonable options, and you can do that for a whole career and be the expert in your area, just like there's a critical care person in your group. We're going to talk about private practice. So there's multiple ways to do this. You can own your own office like I did. I actually opened my office and off I went. You can join a multi-specialty group and you can be put in as sort of like the ortho person. You can also join an orthopedic specific specialty group, and they all have their pluses and minuses. This part's kind of important, and this has to do pardon me, this has to do with how you get paid. All right. So a lot of people don't have a lot of knowledge in this because they haven't been out where this is really relevant. But you can get paid a salary plus a bonus that's based off of something like RVUs, right? You can also be in what's called an eat what you kill model, which is that you pay a percentage of revenue to the group. But most people will do some sort of salary plus RVU. Now, this is where it gets a little tricky. So the RVU value, because an RVU equals a dollar amount, the RVU value for a family medicine doc or an emergency medicine doc are actually almost identical. And these numbers vary. I'm just going to give you an example. So in ER, in family med, the RVU value might be $40. And for ER, it might be 41. But we see more stuff and we see more acuity and we see more complicated patients in family med, so we make more. Ortho's like 70. So for the same thing that you're doing at 41, they're getting $70 per RVU while you're getting 40. So when you see people who come out and they go out into private practice, you really have to take a look at how you're credentialed, and this is a big deal because when you know, our specialty is a hospital-based specialty, so it's really built for doing things in the hospital. When they see your credentials out in private practice, like what the heck is this person doing in a clinic when they're EM and they should be hospital-based? So when you're doing your credentialing, it's really important to get credentialed under the ortho and not under the ER, because that makes a huge difference in how you're reimbursed. So the way that I did that is that I rolled up with an ortho group as part of them under their tax ID number so I could bill like them, and I got the same RVU basis as the orthopedic surgeons. Now, I actually recently sold my practice because I'm just tired of managing it. And I rolled up with an ortho group, but I came in as a full partner. And so I'm considered as an ER sports guy, I'm exactly the same as the hip replacement guy, and I'm exactly the same as the sports surgeon, treated the same power, same everything. And this leads to another part, which is we're not PAs, right? And the problem is when they look at non-operative ortho, we're kind of looked like as PAs, which is unfair. We do a lot more and we are capable of doing a lot more, but we need to preach that and sell that on a regular basis. I am not your PA. I am a practitioner. I specialize in non-operative orthopedics, which is 90% of orthopedics. I've actually had this conversation more than once where I have an ortho guy come in and talk to me, and I say to him, and you don't get to do this in ER, but it is satisfying. Go, I don't need you. My patients come to me. I make the decisions on where they go. So you need me and I don't need you. So here's kind of how this works. Be good, be fast, take good care of my patients, be nice, and send them back. And if you do that, I'll send you every surgical patient completely packaged and ready to go. And you can do what you like to do, which is go to the OR. And if you don't do that, I'm going to find the guy you don't like the most, and I'm going to start sending to him. Do we understand each other? And they all go, yes, we understand each other completely. And then you're dealing from a position of equals. So I'll have ortho guys call me and ask, what do you do about this? I call them all the time because I don't swing the big chrome hammer. And we have a very collegial relationship, right? And that's really important. So when you go into an employment area, you want to make sure that you're being looked at properly and not like he's a PA and I only have to pay a PA $100,000 a year instead of what I'm paying this guy. And it can be done because I've done it, and there's other guys in the country that have done it, and it's been very successful. Now, you got to practice. How do you get bodies? In an ER, they show up. In a practice, they don't, right? So one of the reasons we're kind of second-class citizens in the healthcare hierarchy is because administrators know that people are coming to your ER to come to the building and not to you, right? So if you're there or not there, they're still coming to the building, right? So the heart surgeon can take his patients and leave, and it directly affects the revenue. But if one of us leave, it doesn't really make a lot of a difference, really, because they just put another person in. That's our weakness. There's strengths there too. You can also get a job every 5 feet, and you can manage your career well, but that's the balance. When you're in private practice, that ain't the case. So one of the things you got to consider is how do you get people to realize your brilliance and get them to come see you, especially when you're a market full of people that are well trained and they all went to Harvard and they all were the assistant team physician for the Toledo Mud Hens and Fellowship. So one of the ways that I did it is my clinic is called Boca Walk-In Orthopedics and Sports Medicine. Now, when I sat there and thought about how do you build this, what are we really good at besides procedures? I'm running a couple of minutes over just because I'm catching up, but I'll wind up. Don't worry. We're good at unscheduled episodic, aren't we? Isn't that kind of what we do? So I don't care if you hurt your knee 5 minutes ago or 5 months ago, I'm still there. So that unscheduled episodic method is a great way to get people in the door, but the attitude is not treat them and street them. The attitude is treat them and keep them forever and ever and ever, because every touch point's another touch point, which is another touch point. And what I want to be is your primary care orthopedic guy, your non-surgical orthopedics. I'll do your arthritis. I'll see your back pain. I don't write prescriptions. I do injections. I'll do everything you need me to do as your primary care ortho. And if we fail conservative management, then I'll send you on to a surgeon that's perfectly happy to perform a surgery on you. So when you're putting it up for an individual, there's basically 3 different directions, right? If you join with a group, you can get internal patients. Internal patients are you join up with a 15-person group and the ortho guy doesn't like doing shots, so he sends them to you. And that's fine, and it gets you busy. The problem is you're kind of a PA then, right? Because you're just doing a procedure for the ortho guy who doesn't feel like doing it. It's a decent way to build, but that's not where you want to be. And if you decide you want to leave, you don't really have a lot of leverage when it comes to people, do you? Because they're all internal referrals. And if you leave, they're like, oh, where'd that guy go? That's just it. In a perfect world, what you want to build is external patient base. These are people who are coming to you as a destination. And this, of course, takes time, right? So the way that I slipped this for me, because I opened this, I was working in New York. I wasn't working here. I'm in Boca Raton, by the way, Florida, where it's 65 and we're freezing to death. So I went external, and that was the walk-in orthopedics. That was, how do I get people in the door? Come see me. I'll see you today. No problem. Come in. Bring your friends. Anything you want. I went from 0 patients to operational break-even, which is a business term, which means about 90 patients a week in about 3 months. And normally that takes about 18 months to 3 years if you're doing it the slow way. And, my concept is I heavily market direct to consumer. I'm a great alternative to the ER. Skip the ER. Why sit over there? Come see me. I can take care of you today. And this is a way that I sort of built up the practice. And when I went to go merge with the other group, and I did that because of contracting and benefits and stuff like that, I didn't come in as a PA. I came in as a full partner to everybody else in the group, and nobody had an objection because I generated as much money as the hip surgeon. And that's how you have authority and the ability to do stuff, is that if you control the business and you're the generator of the revenue, you have leverage and you have power and you can be treated well. So lots of great opportunities in sports medicine. For those of you who are residents and fellows, I've been doing this for a while. I love what I do. I like taking care of people. They get better. They say thank you. When you work in business and you make an extra 10 cents in profit, or you sell a bit more shoes, you're not really saving mankind, are you? You're just sort of making a bottom line look better. But we get to actually help people, and that's actually pretty cool. And regardless of anything else, that's what makes the difference between working in finance or working for Nike. This is really a 3-hour talk, and that was 21 minutes. So I will stop there and open it up to questions.
Hey, Jace, how are you?
Good.
Question for you. Do you feel that having a master's, like an MBA or a master's in healthcare administration, like you have, is an important thing to have to start a private practice on their own, where somebody who might go into not a private practice wouldn't necessarily need such a thing?
I should have known you'd ask that question. Okay, so this is actually a great question. I used to say that getting an MBA doesn't make you happy. You just better understand why you're miserable. But the reality is, we're trained in medicine and this is business, and any information you can get that arms you is better than no. So, yeah, it actually is valuable. It's valuable for our credibility when we go have conversations, but more importantly, it's valuable for protecting yourself. I mean, I read my own contracts. I don't hire a lawyer. I can negotiate a deal. I can read a spreadsheet and I can figure out where it's wrong. And I learned that in business school. It's annoying, it's work, but it's a different way of thinking. So yes, I think it is.